Every 66 seconds, someone in this country develops dementia, and by the time this video is over, several more families will hear that word for the very first time. For some of them, the cause won't be age alone. It won't be fate. And it won't be some mysterious process nobody could have seen coming. Sometimes, the trigger is sitting in plain sight on a bathroom shelf, tucked inside a weekly pill organizer, or refilled month after month so routinely that no one ever stops to question it. A medication, one that was prescribed with good intentions, one that may still have a real purpose, but one that can also cloud memory, dull attention, slow thinking, and in some people, imitate the early signs of dementia so convincingly that families assume the brain is simply getting old. I'm Dr. Karen, and after years of working with older adults, I can tell you this with complete honesty. One of the most dangerous assumptions in medicine is that every new memory problem in later life must be caused by aging. I have seen people who were sharp, independent, organized, and mentally quick began to slip in ways that seemed deeply alarming. They forgot appointments, repeated stories, lost their way on familiar routes, struggled to focus, misplaced words, and everyone around them, loving families, busy clinicians, even the patients themselves, reached for the same explanation. Well, maybe this is just what happens now. But sometimes it wasn't what happens with age. Sometimes it was what happens when the brain is exposed day after day to medications that interfere with the chemicals it needs to stay clear, alert, and capable of forming new memories. That is what this video is about. Today, I'm walking you through 9 medications and medication categories most closely associated with memory problems, cognitive fog, and medication-related decline in older adults, counting down from the ones that often slip under the radar to the one I consider the most dangerous of all. And I want to be very careful here. This is not a video telling you to stop your medications. It is not a video saying these drugs are always wrong, and it is not a promise that every memory problem can be reversed by changing a prescription. What it is a wake-up call, because many people are never told that certain medications, especially in older adults, can affect memory, attention, reaction time, learning, and even the overall burden on the aging brain. Some of these drugs are over-the-counter, some are handed out casually, some are prescribed for sleep, allergies, bladder problems, acid reflux, pain, anxiety, or mood. And some are so common that people would never dream they could be contributing to the very symptoms they fear most. Watch closely for number 3. It's prescribed to millions of people for a condition that sounds completely routine, and yet among its drug class, it has one of the most troubling reputations for cognitive side effects in older adults. And stay all the way to number 1, because the biggest threat isn't always one pill. More often, it's the combined burden of several. Let's begin. Number 9. Diphenhydramine, the harmless sleep and allergy pill that often isn't harmless at all at number 9, is a medication almost everyone recognizes. And that's exactly why it worries me, diphenhydramine. Most people know it by the brand name Benadryl. It's the little pink pill people reach for when they can't sleep, when their allergies flare up, when they feel stuffed up with a cold, or when they just want something, anything, to knock them out for the night. It's cheap, it's easy to find, it doesn't require a prescription. And because it sits openly on store shelves, many people assume it must be gentle. But in an aging brain, diphenhydramine can be anything but gentle. The reason comes down to a brain chemical called acetylcholine. Acetylcholine is deeply involved in attention, alertness, learning, and the ability to form new memories. It is one of the key messengers the brain relies on to stay mentally sharp. As we age, the brain becomes more vulnerable to anything that disrupts that system. Diphenhydramine belongs to a class of medications known as anticholinergics, which means it blocks acetylcholine. That's why it causes drowsiness. That's why it can dry the mouth and eyes. And that's also why it can leave older adults foggy, slowed down, and forgetful, especially when taken regularly. What makes this especially dangerous is how often people take it without thinking of it as a real medication. They'll say, "Oh, I'm not taking anything for sleep," and then later mention a nighttime cold medicine, a PM pain reliever, or a nightly antihistamine that contains diphenhydramine. And that's the trap, because in many cases, it isn't just Benadryl by itself. It's hidden inside sleep formulas, nighttime products, and combination cold medicines under different labels. Over time, that repeated anticholinergic effect can add up. And when I've seen older patients use it night after night for months or years, the pattern can be striking. Increased daytime sleepiness, more confusion, slower recall, and a general sense that they are not thinking as clearly as they are used to. Sometimes they notice it. Often their family notices it first. What should you do if you take it? First, don't panic. And don't stop anything important without talking to your clinician. But if you are using diphenhydramine regularly, especially for sleep, treat that as a conversation worth having. There are often safer options for allergies and better long-term strategies for sleep than relying on a sedating anticholinergic every night. Because one of the biggest myths in medicine is that over-the-counter means low risk. For memory in later life, that is simply not true. Number 8. Proton pump inhibitors. When the medication helping your stomach may be complicating your brain. At number 8 are the drugs millions of people take for reflux, heartburn, and chronic stomach acid symptoms. These are proton pump inhibitors, often called PPIs. The familiar names include omeprazole and esomeprazole. They can be incredibly effective. For some people, they are absolutely necessary. And I want to be fair about that. This is not a medication category to demonize, but it is a category people often stay on far longer than they should. And that is where concern begins to grow. Here's the issue: stomach acid is not just there to make you miserable after spicy food. It serves real biological functions. It helps break down food and supports the absorption of important nutrients, including vitamin B12, magnesium, and calcium. When stomach acid is suppressed for long periods, some people begin to absorb those nutrients less effectively. And that matters because B12 in particular is critically important for the brain and nervous system. Low B12 can contribute to fatigue, numbness, confusion, poor concentration, slower thinking, and memory problems that can look frighteningly similar to early cognitive decline. Now, to be clear, the research on PPIs and dementia is mixed. Some studies suggest an association, others do not confirm a strong direct causal link. So I would not present this medication as a proven direct cause of dementia in every person who takes it. That would be too simplistic. But what I will say is this: if an older adult has been taking a PPI for years, is developing brain fog or cognitive symptoms, and no one has ever checked their B12 or reviewed whether the medication is still truly needed, that is a missed opportunity. Because sometimes the problem is not the acid medicine by itself. Sometimes it is what long-term use quietly sets in motion. That is why I encourage people to ask better questions. Do I still need this every day? Is the dose still appropriate? Could this be stepped down? Could lifestyle changes, meal timing, weight management, or a different category of acid control be enough now? And most importantly, has anyone checked whether this medication has left me low in the very nutrients my brain depends on? A good medication review is not anti-medication. It is pro-clarity. And that matters more with every decade of life. Number 7. Bladder medications. The hidden trade many seniors were never told they were making. Number 7 is a category that many people feel embarrassed to talk about, which is one reason it so often escapes scrutiny. These are bladder control medications, especially older drugs such as oxybutynin. If you've ever dealt with urgency, overactive bladder, or the constant fear of not doing it to the bathroom in time, then you know this problem can completely take over daily life. It affects confidence, thought leap, travel, social outings, exercise, even the simple willingness to leave the house. So when a medication seems to help, people are understandably grateful. But here is the hidden cost. Many of the older bladder medications work by, you guessed it, blocking acetylcholine, the exact same memory-related brain chemical we talked about with diphenhydramine, and oxybutynin in particular has long raised concern because it can cross into the brain and exert strong anticholinergic effects there. That means the medication calming the bladder may also be contributing to brain fog, slower thinking, forgetfulness, or increased confusion in older adults, especially with prolonged use. This is one of the most painful medication trade-offs because people are rarely told the full picture. They are told it may dry the mouth. They are warned about constipation. Maybe they are told it can cause drowsiness. But many are never told that it may affect cognition too, so they begin to forget names, lose track of details, misplace things more often, or feel mentally off, and the change gets blamed on age rather than the prescription. That is a serious problem, because when a side effect is mislabeled as aging, it often continues for years. The hopeful news is that bladder treatment has evolved. There are newer options that do not carry the same degree of anticholinergic burden, and for some people, pelvic floor therapy, bladder training, fluid timing, and other strategies can meaningfully help as well. Now, not every patient can simply switch, and not every case is simple. But if you or someone you love has been on an older bladder medication, and memory has clearly worsened over time, that is a conversation worth having soon, not someday, because preserving dignity in the bathroom should never require quietly giving away clarity in the mind, unless there is truly no better option. Number 6. Statins, a more complicated entry and one that deserves nuance at number 6, is a category that surprises people. Statins, atorvastatin, simvastatin, pravastatin, and rosuvastatin. Now let me tell me something very important right away. Statins save lives. For many people, they reduce the risk of heart attack and stroke and are absolutely worth taking. So this is not a simplistic anti-statin message. In fact, the research on statins and cognition is mixed, and large studies do not show a consistent pattern of long-term dementia harm across the board. That matters. But here's why I'm still including them. Because in the real world, some patients do report memory changes, mental fog, or reduced sharpness after starting certain statins, particularly higher doses or those more likely to cross into the brain. And even if the overall evidence remains mixed, those patient experiences should not be mocked or ignored. The brain is a cholesterol-rich organ. Cholesterol is part of cell membranes and involved in how nerve cells function. That does not mean lowering cholesterol is inherently bad for the brain, but it does mean the relationship is biologically complicated. Some people tolerate statins beautifully. Others do not. And older adults are especially likely to be on multiple medications at once, which makes it difficult to identify what is driving cognitive symptoms when they appear. This is why I consider statins an evaluate carefully category rather than a clear villain. If someone develops new brain fog after starting one, the right response is not, that can't be the medication. It's also not, throw it away tonight. The right response is, let's review the timeline. Did symptoms begin after the dose changed? Would a lower dose work? Would a different statin be better tolerated? Is there another cause? Sleep apnea, low thyroid, B12 deficiency, depression, dehydration, another medication. Good medicine lives in that middle ground, because the worst thing we can do is turn nuance into dogma. If a statin is protecting your heart and brain from stroke, that matters enormously. But if it's also affecting your cognition, and nobody is willing to revisit the plan, that matters too. And older adults deserve that conversation. Number 5, benzodiazepines. The medications that calm anxiety while often slowing everything else, at number 5, are some of the most common and most misunderstood medications in older adults. These are benzodiazepines. Drugs like lorazepam, alprazolam, diazepam, and clonazepam, people take them for anxiety, panic, sleep, tension, or simply to feel like their nervous system will stop racing for once. And in the short term, that relief can feel profound. If you've ever been unable to sleep, unable to settle, unable to quiet the mind, then you understand why these medications can feel like a lifeline. They work, that's the truth. But they often work at a price. Benzodiazepines increase the effect of GABA, one of the brain's main calming signals. That can reduce anxiety and create sedation. But in older adults, that calming effect often spills into other areas too. Attention, learning, reaction time, memory formation, balance, and overall mental sharpness. That's why people taking them may feel groggy the next day, why they may seem slower, why falls become more likely, why they sometimes describe feeling not entirely like themselves. And one of the hardest things about this category is that long-term use creates dependence far more often than many people realize. The medication that once seemed to solve anxiety or insomnia can eventually become part of why the person feels unable to cope without it. Worse, stopping benzodiazepines abruptly can be dangerous. Let me repeat that clearly. Stopping a benzodiazepine suddenly can be dangerous, and in some cases life-threatening. So if you are taking one, please do not treat this as a cue to quit overnight. This is a doctor-guided conversation, not a solo experiment. Some people really need these medications. Others can reduce them safely over time. Others may do better with non-drug strategies, different anxiety treatments, structured insomnia therapy, or gentler alternatives. But what should never happen is this: an older adult taking a benzodiazepine for months or years, developing worsening memory, imbalance, or cognitive slowing, and nobody ever considering whether the drug itself is part of the picture, because it often is. And when it is, recognizing that early can make an enormous difference. Number 4. Amitriptyline, the older medication still doing far more damage than many people realize. At number 4 is one of those drugs that stays alive in medicine because it can do a lot of different jobs. That medication is amitriptyline. It's an older antidepressant, but it's often prescribed for much more than depression. Nerve pain, migraines, sleep problems, chronic pain syndromes, and sometimes symptoms that seem only loosely connected to mood. And because it's been around so long, it can feel familiar, routine, even safe. But in older adults, amitriptyline carries one of the heaviest anticholinergic loads still found in commonly used medications. That matters immensely, because at some point, what patients experience stops looking like a rare side effect and starts looking like a predictable consequence of how the drug works. Dry mouth, constipation, blurred vision, urinary retention, drowsiness. And very importantly, confusion, slowed recall, poorer concentration, and memory problems. Sometimes at high doses, sometimes even at doses that seem modest. What makes amitriptyline especially deceptive is that people are often not taking it for a psychiatric reason at all. They're taking it because they were told it might help them sleep better or calm nerve pain. So when cognitive symptoms emerge, nobody links them back to the medication. The person isn't thinking, this is an old antidepressant affecting my brain. They're thinking, I'm just more forgetful these days. That false story can steal years. If you or a loved one is taking amitriptyline, especially nightly and especially long-term, this is one of the clearest examples of a medication worth reviewing carefully in later life. Not because it is never appropriate, but because there are often better tolerated alternatives depending on why it was prescribed in the first place. For some people, the drug was started years ago and simply never revisited. And one of the most dangerous phrases in medicine is, they've just stayed on it, especially when the brain is paying the bill. Number 3, paroxetine. The antidepressant many people assume is routine, but older brains often tolerate it poorly. This is the one I told you to watch for. Paroxetine, commonly known by the brand name Paxil. Now, paroxetine belongs to the SSRI family, selective serotonin reuptake inhibitors, a group often thought of as the more modern, gentler antidepressants. And in many cases, SSRIs really are much easier to tolerate than older medications. But paroxetine is different enough from some of its cousins that older adults need to know about it. Why? Because unlike SSRIs such as sertraline or escitalopram, paroxetine has more anticholinergic activity. That means it carries some of the same brain clouding concern we've been talking about throughout this video. And that is exactly why geriatric prescribing guidelines have repeatedly treated it with caution in older adults. Now, does that mean every older person on paroxetine will have memory problems? No, absolutely not. But it does mean that if an older adult is taking paroxetine and begins experiencing increased forgetfulness, reduced attention, slower thinking, or mental dullness, the medication deserves a very close look. This is one of the more frustrating cases, because people assume all SSRIs are basically interchangeable in how they affect the aging brain. They're not. Details matter. In younger adults, a medication may be merely sedating or not ideal. In an older adult, that same feature may translate into falls, confusion, daytime dysfunction, or measurable cognitive decline. And paroxetine is one of those medications that too often stays hidden under the umbrella of just a standard antidepressant. If depression or anxiety needs treatment, and often it does, there may be other options in the same broader family that place less stress on cognition in later life. That doesn't make paroxetine evil. It makes, and when I talk about not fear, not internet panic, better selection, better follow-up, better medication fit for the brain you have now, not the one you had at 35. Number 2. Antipsychotic medications, often prescribed for convenience, often far more damaging than families realize. At number 2 are antipsychotic medications, names like quetiapine, risperidone, and olanzapine. These medications were developed for serious psychiatric illnesses, such as schizophrenia and bipolar disorder. In some settings, they are necessary and appropriate. I want to acknowledge that. But in older adults, especially frail adults, those with confusion, agitation, sleep disruption, or dementia-related behavioral symptoms, sometimes they are prescribed because a person is restless, or wandering, or not sleeping, or becoming difficult to manage in an understaffed environment. And this is where the ethical line starts to blur, because powerful brain-suppressing medications can sometimes make life easier for a system before they make life better for the patient. That is a hard truth, but it is one antipty. They can reduce movement. They can impair attention and planning. They can increase falls, and in older adults with dementia, some carry serious warnings related to stroke and increased mortality. This is not a trivial category. These, when they are truly necessary, they must be used thoughtfully, at the lowest effective dose, with ongoing reassessment. But what too often happens is this. The drug gets started during a crisis, and then it simply stays. Weeks become months. Months, meanwhile, the family sees their loved one become quieter, flatter, slower, less present. And now, some patients really do need these medications. But if you or someone you love is on one, here are the questions that matter. Why did it start? What exact symptom was it meant to target? Is that symptom still present? Has the dose been? Is there a non-drug strategy that could reduce the need for it? Because no older adult should be chemically dimmed for convenience without the family clearly understands. Number 1. Anticholinergic burden and polypharmacy. The slow, cumulative brain drain almost nobody sees coming. And now we come to number 1, not a single drug, not one brand name, not one obvious villain. The greatest danger on this list is often the combination, the stacking. The quiet accumulation. This is called anticholinergic burden. And when it happens in the setting of multiple medications, it becomes one of the most overlooked drivers of medication-related cognitive decline in older adults. Let me show you how this happens. A person takes diphenhydramine at night to sleep, an older bladder medication during the day, amitriptyline for pain, maybe something else for nausea, a nighttime cold formula once a PM pain reliever more often than they realize. No single pill seems catastrophic. No one every over-the-counter product seems ordinary. But all of them are pushing in, and the brain feels the total, not just the individual parts. That is the piece families miss. That, and frankly, that is sometimes the piece clinicians miss too when medications are being added one by one over years by different prescribers. The result can be devastatingly subtle at first. More fatigue, less focus, a little more forgetfulness, more trouble following a con, more confusion in the evening, less mental stamina, more imbalance, a slower, dimmer, more effortful kind of thinking. Then the family starts whispering the word dementia. And sometimes sometimes what they are really looking at is a drug burden problem that has never been properly accounted for. This is why I consider anticholinergic burden and polypharmacy the number 1 threat on this list, because it hides in plain sight, because it is cumulative, because it is common. And because in some people, catching it, this is also where the most hope lives. Medication-related cognitive decline is not always permanent. Not always, not in everyone. But sometimes, when the burden is identified and reduced carefully, people do become clearer, more awake, more themselves. Families notice it, patients notice it. It can feel, but that only happens if someone looks. And that is why a full medication review is so powerful, not a rushed glance. Not anything new. A real review, every over-the-counter medication, every sleep aid, every allergy pill, every bladder medication, every supplement, every nighttime product, every PRN medication used only sometimes. All of it. Because the brain doesn't care whether a drug came from a cardiologist, a urologist, a primary care clinic, a supermarket shelf, or the bottom. It only feels the chem. And if the chemistry is working against memory, attention, balance, and clarity, someone needs to know what you should do next if any of these sound familiar. So what do you actually do with this information? First, do not panic. Second, do not make sudden changes on your own. And third, do not dismiss what you've been feeling. If you or someone you love has had worsening brain, formal medication review, use those words, medication review, bring a full list, better yet, bring the current bottles. Ask specifically whether any of the medications carry anticholinergic effects, sedation risk, or concerns for older adults. Ask whether any drug on the list is on geriatric caution lists. Ask whether the combination itself is too heavy. Ask whether dose reductions, substitutions, or deprescribing might be possible. And if the answer, you respectfully but clearly. Because older adults deserve better than being told every sign of brain decline is just aging, while no one checks the medicine cabinet. That is not good enough. Also remember this, not every memory problem is medication-related. Sometimes the cause is sleep apnea, depression, dehydration, vitamin deficiency, untreated hearing loss, thyroid disease, an infection, a stroke, neurodegenerative, or several things at once. But medications belong on the list of possibilities every single time, and they are too often left off. The deeper message most families miss. If there is one message I want this video to leave behind, it is this. Aging does change the brain, but medication burden changes it too. And the older brain is less forgiving. A side effect that a younger person shrugs off can be, that doesn't mean older adults are fragile in some hopeless way. It means their care must be more precise, more individualized, more respectful of the brain's vulnerability. When someone gets older, medicine should become more thoughtful, not less, more selective, not more automatic. More willing to ask, is this that question can protect memory? It can protect independence. It can protect the difference between a person who still manages their own day and a person whose whole world has quiet. That is not a small thing. That is everything. Final close. So, now I want to ask you something. Look at your own medicine cabinet. Look at the pill organizer on your counter. Look at the nighttime products, the allergy relief, the blad. How many of them have ever been reviewed with your memory, not your blood pressure, not your cholesterol, not your stomach, not your sleep, your memory, your attention, your ability to think clearly and stay yourself? Because that is the question too many people ever, if any of not next year, not eventually, this week. And if one respectful question can change, could sometimes the answer is, but sometimes the answer is the very thin. If this video helped you connect the dots, share it with someone who needs to see it. Because the most dangerous medication side effects are often not the dramatic ones. They are the quiet ones, the ones that look like aging. The ones that mask the ones that steal clarity so gradually no one notices until they've taken far too much. I'm Dr. Karen. Take care of your brain. Ask better questions. Review every medication. And never assume that common means safe for memory. I'll see you in the next video.